Well, thanks for joining us. We'll be starting in just a minute after we have more folks file into the Zoom webinar room. Thanks for joining us. We're going to get started in just a sec. Hello, everyone. Thank you for joining us here today. I'm Linda Mitchell, CEO of Allergy and Asthma Network. Welcome to this afternoon's webinar. We're in for a really informative session with Dr. Purvi Parikh as today's presenter. I have a few housekeeping items to go through before we get started. First, all participants will be on mute for this webinar. We will be recording today's webinar and we will post it on our website within a few days. You can find all of our recorded webinars on our website at allergyasthmanetwork.org. Scroll to the bottom of the page of the homepage to find our recorded webinars and any upcoming webinars for which you can register. This webinar will be 1 hour in length that includes questions at the end. We will take those questions during the session, so send them to us in the Q&A box, and then at the end of the session, we will ask the questions that we will get to as many as we can before we conclude today's webinar. This webinar is a partnership with the American College of Allergy, Asthma, and Immunology. The college offers CMEs for physicians and attendance credits for all others. You can create a free acai.org account and obtain CME or attendance credits through the member portal for the advanced webinars. All attendees will be offered a certificate of attendance here today as well. No other continuing education credit is provided. A few days after today's webinar, you will receive an email with supplemental information and a link to download the certificate of attendance if you didn't catch it on this session. And we will try to also add a link to the certificate in the chat. So let's get started. Today's webinar is about vaccines, new developments, and how to address vaccine hesitancy. People living with severe asthma and other chronic lung conditions may be at higher risk for severe illness from contagious diseases such as the flu or COVID-19. Vaccine hesitancy was worsened by the pandemic and needs to be addressed by meeting people where they are. In this webinar, Dr. Purvi Parikh will define vaccine hesitancy, discuss ways to work with vaccine hesitant patients, and talk about new vaccine guidelines. It's my pleasure to introduce our speaker, Dr. Purvi Parikh. Dr. Purvi Parikh is an adult and pediatric allergist and immunologist. She is currently on faculty as clinical instructor of medicine and pediatrics at New York University School of Medicine. She completed her fellowship training in allergy and immunology at Albert Einstein College of Medicine's Montefiore Medical Center. Prior to that, she completed her residency at the Cleveland Clinic Foundation in Cleveland, Ohio. Dr. Parikh is board certified by the American Board of Internal Medicine and the American Board of Allergy and Immunology. Dr. Parikh is passionate about health policy and sits on Health and Public Policy Committee for the American College of Physicians. She's also the Allergy and Asthma Network's national media spokesperson, so you'll see her representing us in the media quite a bit. She's made numerous TV appearances on our behalf as well as other media opportunities. Thank you for being here today, Dr. Parikh. I'll turn it over to you now.
Thank you. Thanks so much for that gracious introduction. So this is a very, I think timely topic. We had picked it many months ago, but especially now, given our current political climate, we don't know where things will go with the vaccine hesitancy. And even given the past 5 years as well, we've been seeing this trend, unfortunately. So we'll talk a little bit more about that today. Next slide. So just wanted to give the disclosures, that I'm the speaker, obviously. I speak for Genentech, and I'm a consultant for GSK, and there's no relevant financial relationships that would, put me in conflict with today's presentation. Next slide. So our objectives today are kind of to go over the determinants of vaccine hesitancy, and to prepare practical strategies to help overcome vaccine hesitancy, and also recommend appropriate vaccines based on the current guidelines. Because as I know, they keep changing. And even for us as physicians, we need to constantly be on top of these changes. Next slide. So what is vaccine hesitancy? Next slide. So according to the World Health Organization, there actually is a formal definition. So vaccine hesitancy is a delay in acceptance or refusal of vaccines despite the availability of vaccine services and supporting evidence. And the term covers refusals to vaccinate, delaying vaccines, accepting vaccines but remaining uncertain about their use, or using certain vaccines but not others. So it's not a black and white term by any means, and it doesn't mean that someone is necessarily anti-vaccine. So that's important to make that distinction, because a lot of vaccine hesitant individuals may not be fully anti-vaccine. The World Health Organization has also classified this as one of the top 10 global health threats, as vaccine hesitancy can lead to outbreaks of infectious diseases and deaths, which we have obviously seen with the COVID-19 pandemic. But then even more so now, we're seeing resurgences of diseases we hadn't seen in 30 years or more, such as measles. There was a polio case in New York last year. So it is concerning. We don't want these things to come back. Vaccine hesitancy is especially a risk for asthma patients, prone to vaccine preventable respiratory diseases, as well as high-risk groups like babies, immunocompromised, pregnant women, and those over 65. So unfortunately, this is one of those things where other people's decisions affect everybody else. Next slide. So anti-vaccine and vaccine hesitancy are different. So while some individuals may be completely against all vaccines, the vaccine hesitant crowd is a lot more complex and nuanced and not necessarily against vaccines. And this is actually a good thing, because there's a chance to meet people where they are. And many vaccine hesitant people have then gone on to receive vaccines that they're hesitant about. So this is a population that is amenable to change. Next slide. So my personal experience during the COVID-19 pandemic was that a lot of vaccine hesitant people could be convinced to get the vaccination. They just wanted more information. And more importantly, they wanted their fears and concerns addressed. And the most important thing I noticed was they needed a trusted messenger to address those fears and concerns. So I spent a lot of time educating on the COVID-19 vaccine. I was actually even involved in the clinical trials to get the vaccine approved. And I found that one of the easiest ways to change someone's mind was to find out what bothered them, what they were fearful of, what they were concerned about, and give them the reassurance, but it had to come from somebody they trusted. And many of those hesitant people then went on to receive the vaccine, and many were in high-risk groups. Many were my patients and family members and friends. So, that's what I learned personally through that experience. And I think it can be applied to today's situation and to any vaccine, not just the COVID-19 vaccine. Next slide. So, I also had the opportunity to go with the UN Foundation vaccine initiative. It's called Shot at Life, to Zambia back in, I think there's a typo on the slide, but I went back in 2016. And this was a really unique experience. Even though it was pre-pandemic, we still had vaccine hesitancy then. As you all know, it's not something new. But I learned and saw interesting things. There was virtually no vaccine hesitancy. And you would think, why? Many areas of Zambia, they have less resources than we have today in America or other westernized countries. And moms would walk 3 to 4 hours in sub-Saharan heat to get kids vaccinated because they saw what happened when outbreaks occurred, and measles outbreaks would wipe out entire villages, so they saw the downside of vaccines very closely, and it was very personal for them. And often these clinics operated with solar power. They didn't have consistent electricity, and there were many areas, even in the middle of the night, they'd be using the flashlight on their cell phone. These nurses would be to treat patients. So an area like this, it's like, how would they get the message out, right, about these vaccines and where they would be available? And the really interesting thing was that the government relied on SMS, so text messaging, for vaccine campaigns. And they had a very well organized clinical national digital registry to organize the data. And you'd think, oh, well, how can an area of the world that has very little solar power, or, very little electricity and relies on solar power and has very, very remote areas, how can they transmit SMSs? But the interesting thing is that even though some of these villages may not have had, let's say, running water, electricity, everyone had a cell phone of some sort. And even if it was, one of those old school Nokia brick non-smartphones, all of them were able to receive SMS messages. So this was a great way to kind of mobilize people, and their vaccine rates were very, very good, actually close to 98, 99%. So I thought that was a really interesting and eye-opening experience, and why vaccine hesitancy is so low there, because you see the consequences of not having them. Next slide. So the COVID-19 pandemic, unfortunately, has worsened vaccine hesitancy. And as a result, we've seen a drop in childhood immunization. So it's not only that people aren't getting the COVID vaccine, but they've stopped getting other vaccines too, and especially stopped vaccinating their children. So the influence of COVID-19 on trust in routine immunization, health information sources, and pandemic preparedness in 23 countries showed that this occurred. There was an article that was published in Nature back in 2023. And then also new data showed from UNICEF that there was a declining confidence in childhood vaccines, and up to 44 percentage points in some countries during the COVID-19 pandemic. So even those countries had virtually very little vaccine hesitancy, like Zambia, for example, even now their vaccine hesitancy unfortunately went up as a result of the COVID-19 vaccine. And then unfortunately, as a result, people then became also skeptical about their flu shots. And I know there was an article in AGMC about it, but I've seen that even in my own practice, that I've had certain patients that never missed their flu shot. Now this year I had to, they were a little skeptical to get it after things that they had read or heard about the COVID vaccine. So these were unfortunate unintended consequences from vaccine hesitancy during the pandemic. Next slide. So, if we look at vaccine data, we can see very clearly, what has been going on. So if you look kind of year by year, starting with 2020, 21, 22, and 23, you could see that the willingness to take available vaccines, depending on, the average, in 2020, there was, a very good willingness to take it. But then as time went on, the willingness to take the updated boosters slowly was declining in average. And then if you go to the next slide, kind of willingness to take recommended booster was even less so. Oh, sorry, can you go back one more? I meant the next graph. I said slide, I misspoke. The willingness to take the recommended booster or to get booster when it was available, unfortunately, also started to go down. And then, when we kind of asked patients, how they felt about if the vaccine was safe and effective, luckily, majority of people agreed, but many were unsure, didn't have an opinion. And then there was an increase in people who kind of strongly or somewhat disagreed. So unfortunately, some people formed very strong opinions against this. Next slide. So vaccine hesitancy has caused eradicated diseases to emerge. We know this. Measles, we've seen multiple outbreaks over the last few years. Unfortunately, Canada saw its first measles-related death for the first time in nearly 40 years, which is very concerning. And measles is extremely contagious. Like if we thought COVID is very infectious and contagious, measles is even more so than that. So that's why it's so scary. And just to share with you personally, I'm a new mom of a 9-month-old. My child isn't yet even eligible for the measles vaccine, right? So whenever I hear this, it really is stressful to me because I'm like, he can't even get the vaccine yet for another 3 months. And so these outbreaks can be potentially dangerous to children like him, immunocompromised, pregnant women, you name it, even some asthmatics who might not be able to respond to the measles vaccine, right? So that's very concerning. And 2024 had already seen, I think by May, double the measles cases in all of 2023 for the whole year. So it is rapidly progressing, and this is a big concern. Polio, which we thought we would never see again, I thought I would never see in my lifetime. Again, last year in Rochester, New York, there was a polio case diagnosed, again, in a community of unvaccinated individuals or vaccine hesitant individuals. So that concerns us, right? What else will emerge that we thought we didn't have to worry about anymore? Next slide. So what causes vaccine hesitancy? Next slide. So, determinants of vaccine hesitancy, it's complex. A systematic review and meta-analysis basically to look at these factors was done across 185 countries, and they focused mostly on COVID-19 vaccine because that was the most recent and readily available data. And it revealed that there was an association between vaccine hesitancy and not having influenza vaccine. So if you were already skeptical of the flu vaccine, those people were also skeptical of the COVID vaccine. A mistrust of vaccines, which makes sense. Then there was complacency, where people thought, well, this won't affect me. Especially now, complacency, I think, is much more so than the earlier days in the pandemic, because at least then many people were motivated to get vaccines because they wanted to get out of lockdowns. They wanted to go, to their favorite restaurants or shows or other places. And there were a lot of vaccine mandates, which I know are controversial, but that motivated people to at least get initially vaccinated, even though now, ironically, a lot of those mandates have made people hesitant. So everything's a double-edged sword. But now people are complacent because there isn't that strong motivation. People have kind of forgotten about COVID, even though it's still very much around. Interestingly enough, being female was an association with vaccine hesitancy, and I'm not quite sure why. Myself being a female, I'm very pro-vaccine, but for some reason, there is an association there. And I don't know if that's because, women are, reading more of this misinformation or have more access to misinformation. I'm not sure. Or because, women are of childbearing status and there's a lot of hesitancy because of fears of it affecting reproduction, which we know is not true. Pregnancy, again, was associated with vaccine hesitancy. And I saw a lot of that during the COVID pandemic, even though pregnant women were much more at risk of not getting the vaccine, as well as their fetuses being much more at risk. They were the most hesitant group. And we saw a lot of bad outcomes in individuals who forewent that vaccine. So safety concerns, obviously. And then there's also an association with people who take more like traditional herbs, or non-traditional medications, that there's a stronger association with vaccine hesitancy in those individuals. Next slide. And then among those living in an urban setting with higher education, low income earning, were also associated with, interestingly, higher vaccine acceptance. So that kind of echoed with things which I saw in Zambia. That it didn't necessarily mean like wealthiness didn't make a difference on who was more accepting or not. Education sometimes made a difference, but not always. So it really depends, I think, on personal experience and personal environment and access to information. And it was proposed by a working group that these factors can be classified into 5 domains that kind of shape people's decision making regarding the acceptance or rejection of vaccines. So environmental, that's huge. Personal, social, and so those 3 are really very important. So the people you surround yourself makes a difference on how you'll decide whether or not to take one, your own personal experiences with vaccines, and who you socialize with. And that can include online too, not just in person, so social media. Safety was a determination, and then other vaccine-related factors. Like some people don't like needles, some people don't like how they feel, or maybe get bad side effects to vaccines. So those things were also determinants of hesitancy. Next slide. So environmental factors. This study looked at different environmental factors. So socioeconomic level made a big difference. Education, income, occupation can influence vaccine hesitancy, and lower socioeconomic status often associated with higher levels of hesitancy. But interestingly enough, even people within the healthcare space, there was big disparities depending on what you did in the healthcare space. So if you looked at physicians, nearly 98% based on data from the AMA had taken the COVID-19 vaccine. But then if you looked at nurses, for some reason it was significantly lower, even though, both individuals are in the healthcare space, both individuals were, side by side treating COVID-19. So I found that really interesting. And very similar data exists with the flu vaccine, even pre-pandemic. So again, I don't know exactly why, but that's kind of the data that's out there. And then access barriers. So financial challenges, geographic constraints, lack of awareness about available vaccines can also hinder vaccine uptake. And that's actually happening now, I think, because there isn't as much public information about, let's say, COVID vaccines or flu vaccines. Those campaigns aren't really going. People don't even realize that there's new boosters available, for example. So even some of the patients I see on the daily basis, when I tell them, oh, did you know there's a new COVID shot out? Did you know that you qualify for this new RSV vaccine? They're actually surprised. So I think a lot is lacking currently in access in terms of patient education. And even maybe being able to go and get a vaccine. People might not be able to take time off from work or what have you. Complacency, again, people are burnt out, tired from the pandemic. So, the need for vaccination may feel very low, and their perceived risk of vaccine preventable disease may seem low. But that is, vaccines are a victim of their own success. That's primarily due to successful vaccination programs. Then people kind of become complacent, ironically. Next slide. And then again, there's a lack of information or misinformation. So it's bad enough that a lot of those public awareness campaigns are no longer there, or there's not good education out there, right, for the public to see about newer vaccines or vaccine guideline changes. But on top of that, there's a lot of misinformation. So there's a lot of things that's out there that are untrue as well. So people aren't getting the good information, but they're getting bombarded with bad information. And then resistance to vaccine mandates and government policies. If you tell someone that they have to do something, they don't want to do it, right? So that's part of the problem. Some of these mandates are important because we need to protect the general community. So initially, when we had thousands of people dying every day from COVID, the mandates, I could see why they made sense, right? There was a large public health risk and a rush to get everyone some level of immunity. When you have children who have communicable diseases, there has to be mandates to attend schools because you could be putting other children at risk. And they're very, very, very vulnerable with their developing immune systems. So some make sense. A lot of these policies make sense, but unfortunately, when people are forced to do something, that makes them more hesitant and less likely to want to do something. So these requirements, ironically, promote the hesitancy among individuals who perceive these measures as impinging on their own personal freedoms or autonomy. Next slide. And then there's a lot of personal factors. There's a lot of individual beliefs and preferences. Health risk perception and medical interventions can shape vaccine hesitancy, with some individuals preferring natural immunity or alternative health practices. Cultural and religious beliefs are very important, and we need to take these into account when we counsel our patients. Many may influence attitudes towards vaccinations with views as contrary to their cultural or religious practices. There may be concerns about the use of certain animal-derived ingredients or perceived interference with natural immunity. And then perceptions of risk. This is really important because many vaccine preventable diseases, the relative risk of vaccination can influence their hesitancy. So patients or individuals may underestimate the severity of vaccine preventable diseases or overestimate the risks associated with vaccination. So this happened with the COVID vaccine, many would cite certain side effects of the vaccine as being reasons they didn't want to get the vaccine. So they would say, oh, I don't want to get a blood clot, or I don't want to get myocarditis, inflammation on the heart. But then they didn't realize that should they get the real virus of COVID, the risks for those two things were significantly higher. So those are just examples of that, the risk perception being skewed. And then the same thing goes for our old vaccines, right? For childhood preventable diseases, because those vaccines were so effective in reducing childhood preventable diseases, people think, oh, well, we're not at risk anymore because everyone's vaccinated, but they don't understand that that risk could return if we stopped then vaccinating. So all of these things are very important. Next slide. So personal issues, and this one is probably one of the harder things to address, is trust in healthcare providers and institutions. So this is key. This is why those trusted messengers are really important. And the trusted messengers don't have to be doctors, but often there's many studies coming out of the pandemic that people trusted their own personal physician's advice on the vaccine much more than, you know, what Dr. Fauci would say, or the Surgeon General would say, or any other, you know, public health official would say. Previous negative experiences, so we can't discount that. If someone has had an adverse reaction to a completely unrelated vaccine, it will still affect how they feel about all vaccines. And then historical trauma and discrimination. So there's, you know, a history of exploitation or mistreatment within healthcare systems can contribute to vaccine hesitancy, particularly among marginalized or minority communities. So we saw this a lot in the Black or African American community. They had, you know, justified mistrust of the healthcare system because of things like the Tuskegee experiment and other things where they had been exploited or mistreated. So as a result of that, there was a lot of hesitancy in that group, even though they were at higher risk. All people of color were at higher risk of morbidity and mortality from COVID-19. So a lot of what we did was we worked with trusted messengers in these communities, worked side by side along physicians that they trusted, religious leaders that they trusted, kind of dispel a lot of this mistrust and a lot of this trauma, and it gets it passed down. So even you may think that you know, your grandmother's beliefs might not influence the grandchild, but it does, because those beliefs are passed down to the mother or father and then to the child. So it's generational trauma as well. Next slide. So social factors. This is also very important in the day and age of social media and social networks. Even though we were all isolated from one another, the exchange of information was maybe even more so than it usually is, because everyone was kind of stuck on their phones or their computers. So your social networks and peer influences make a big difference. Obviously, opinions and attitudes of friends, family members, and social networks, along with your peer discussions, right? Because someone may in your friend group might say, oh, you shouldn't get that vaccine, I heard XYZ. And then you're like, oh, well, my friend is saying this, I trust them. Media and information sources, this is a double-edged sword, because sometimes the media is very helpful in bringing light and attention to things, but then there's also distrust of the media as well. So again, it depends on how people view the media, and same goes for social media too. There was a lot of very good information coming out during the pandemic, and a lot of healthcare providers used social media as a tool and did a great job of disseminating very helpful information to combat vaccine hesitancy. But then the flip side was there was a lot of misinformation as well that we had to work against. And we found, and studies have found, that unfortunately the misinformation travels faster for some reason than the good information. I think there's a saying that lies travel twice as fast as the truth, or something like that. But unfortunately, it applies here as well. And then stigma and discrimination. So certain vaccines can be perceived to identify an individual as part of a stigmatized group. So people may avoid the vaccine to avoid being labeled. So I mean, we see this a lot in asthma as well. A lot of times people don't want to come to terms with their diagnosis or a chronic illness. It's not just asthma, it can be any chronic illness. So they kind of shun treatment because they're like, I don't want to be associated with that label. So that unfortunately plays a role as well. Next slide. So we went through misinformation, disinformation. Again, social media is one of the worst because it's in everyone's hands. The internet is one of the worst places too, because even if you're not on social media, there's a lot of fake websites out there that look very realistic. They look very much like trusted medical information. Next slide. And then safety considerations. We touched on this, so I won't necessarily rehash it. But again, a lot of people have concerns that, what they're taking is harmful. There's a lot of misinformation that it will do harm to women and fertility. And that was one of the main things. I think I was kind of the trusted messenger amongst the group of childbearing women, because even a lot of my own friends and family members who were afraid to take the vaccine, I would tell them, listen, I'm taking it. I have the same concerns as you. I wouldn't take something if that was true. And then the vaccine efficacy, there was a lot of questions around that. But I think, again, as a medical community, we have to do a better job of explaining to people what vaccine efficacy means. And once you do, most people understand that a vaccine doesn't make you bulletproof. A vaccine doesn't make it so you never get something. I wish that would be wonderful. What it does is that if you do get it, you're much less sick, right? And then you're much less likely to pass it on to somebody else who it could get very, very sick. And I think if you explain it that way, people understand better what efficacy means. Because people had this misconception that, oh, I still got COVID after the vaccine, it must not work. No, it actually probably kept you out of the hospital. It probably shortened the duration of your illness. It made you less likely to infect somebody you care about. So these are the important messages, I think, that get lost when people think about vaccine efficacy. And then the ingredients. This has been a huge thing, and it's coming back into the news again. But people are very hung up on certain ingredients. So preservatives, adjuvants, and they have a lot of misinformation that these things are harmful. But many of these ingredients are things that people are eating and drinking on a daily basis and have no idea. So one of the main preservatives in both COVID vaccines, or all three, is in toothpaste. Many people say, oh, but there's cyanide and arsenic and this and that. And there was a great graphic. I wish I had remembered to put it in the presentation, but it was showing that a lot of the things people are worried about in vaccines are also in an apple, right? That people will not think twice about eating. So again, all of this, the misinformants kind of blow these things out of proportion, and people don't realize the risk or the perceived risk. Next slide. So again, safety and vaccine related questions, a lot of this we went through, but there are concerns specific to various vaccines. So many people will be comfortable with some, but not all, or they'll want to space them out. So again, this all falls under vaccine hesitancy. Even though they might be not completely against it, they may limit how many vaccines they will take, or they might skip a booster or skip a dose, and that can have downstream consequences. Next slide. So how do we address this? How do we fix this problem, which is here to stay, unfortunately, and growing? Next slide. So there's a lot that can be done because healthcare providers play such a critical role in addressing these barriers. People really trust, again, the doctor or nurse or physician assistant or nurse practitioner that they interact with the most, because you guys already have a relationship. And I've heard it, I'm sure many of you have heard it, that patients will say, I don't know about this vaccine, but doc, if you tell me to take it, I trust you, I'll do it. And I'll say yes. I'm like, I recommend it for you. I've recommended it for myself and for others. The COVID-19 pandemic highlighted how important and how influential the roles are of physicians in advocating for vaccines. But I would go one step further and say all healthcare workers, right? Because some people may interact more with the nurse or have a closer relationship, let's say with the nurse at their physician's office, or the nurse practitioner or PA or whoever. Every member of the healthcare team, I think, can really be influential here. And it can work negatively too, because I've had instances where I've talked to patients where they said, oh, but the ultrasound tech just told me that I shouldn't get a vaccine because it can give me a heart attack. And I'm like, it drives me crazy. So it can go both ways, but I'm just showing you that everyone has influence. Anyone who interacts with the patient has influence, from the front desk all the way to the end checkout person. A recent study of close to 2,000 US adults, including minority and rural populations, demonstrated a strong link between trust in one's physician and vaccination rates. So that's just the doctor alone, who's probably the busiest person and maybe the person you may or may not interact with regularly. So imagine if the whole healthcare team was kind of on the same page. Those who had previously declined vaccinations were more likely to accept if they trusted their healthcare provider. And that was my own personal experience. Primary care providers were particularly influential, of course, due to their very close relationships. But of course, allergists are too, because we have very long-term relationships with patients. We see everyone from childhood through adulthood. Many individuals view their primary care doctors as their most effective messengers regarding vaccines, with a significant portion expressing willingness to receive vaccines during routine visits. And pediatricians play a huge role in this. Family practice doctors, again, all for the same reasons. And those are kind of the ages, especially for childhood vaccines. Those doctors are very important. OBGYNs, same reason. And because pregnant women are such a vulnerable population and newborns, the OB is, again, very important. Everyone on that OB team. Educating healthcare workers about the reasons behind vaccine hesitancy and providing them with multiple strategies can lead to significant advances. So a lot of other doctors, nurses would come up to me and say, well, I want to convince people, but how can I convince them if they're against it? And there are ways. So people just want to feel heard and they want their fears addressed. So I found it helpful to always ask, well, what exactly bothers you? What are you worried about? And then when they tell you, then you can tailor your message to that. So if someone says, well, I'm afraid if I get the vaccine, I won't get pregnant, then I can explain, well, that's not true. And in fact, certain populations saw an increase in fertility after vaccination, probably because it helped them, protect them. And then there's a whole slew of things, people bring up the blood clots or myocarditis, and then I can explain to them, well, actually, those things are much more likely to happen if you don't get the vaccine. So then, and most people are reasonable people and they understand, they just want to be heard and they want their fears to be heard and addressed. And it's essential for doctors, physicians, clinicians to begin with a thorough understanding of the causes of hesitancy and to brainstorm strategies to address the concern. That's the main thing. Next slide. So again, this kind of same thing, but understand the root cause. By knowing that, it makes it so much easier to address people's concerns. Collecting information and gain insights about perceptions is very helpful. One group of people may have totally different concerns than another group of people, and understanding those concerns can make a huge difference. Monitoring social media and websites within communities can help provide collateral information and help in early identification of a potential challenge in beliefs. And this practice can also identify potential rumors and misinformation, allowing timely action. Next slide. And then it'll align the intervention with the root cause. So again, these interventions or these conversations should be based on what the problem is. Just kind of spewing facts at people, oh, this is safe and this is effective. You have to tailor your message to who you're talking to, right? Whether it be a woman or an older man or the parent of a caregiver. Many people have, each person has a different concern and a different fear. So again, that tailoring is really important. And interventions don't have to be something complex. It could be as simple as active listening, peer discussions and education regarding the risks and benefits. And the population that mistrusts the healthcare system or remembers previous adverse effects or trauma related to vaccines requires a complex intervention to gain trust. And this could include enforcement of regulatory initiatives on vaccine safety or implementing reporting systems for adverse effects. So again, tailoring your message is really important, but you are kind of the expert, you meaning all of you today, in what your community needs, because you know your community the best, right? My patient population might be very different than someone's in Iowa or the South or what have you. So, but each healthcare worker knows their own community the best. Next slide. And then again, effective communication helps. If you have harsh language or you're not, or people feel like they're not being heard, they kind of shut down. And this seems like common sense, but again, a lot of those things, like I mentioned before, active listening, addressing people's concerns, hearing their concerns, really goes a long way. It helps them get their guard down, drop their barriers to connecting. And this is true for anything, right? But especially for vaccine hesitancy. Next slide. And then some practical strategies in current vaccines. So I wanted to take kind of the end part, and then we can focus on questions to go over what the current vaccine recommendations are and just some, practical strategies. So can we go to the next slide? So again, I mentioned this already, so sorry if I sound like beating a dead horse, but don't lecture, berate, or isolate people. You want people to have a positive vaccination experience, so they'll want to continue to get vaccines. I hear so many times, oh, I was so pro-vaccine, and then I got the COVID vaccine, and X, Y, and Z happened, and now I'm turned off of all vaccines. Or, so again, you don't want to force something down somebody's throat. Then they're less perceptive. Find out if the patient is experiencing fear, as we mentioned, and trusted messenger. This is key. So we did a lot of vaccine outreach during the time, and NYU Vaccine Center, and we partnered with religious organizations. So we would have town halls with churches, mosques, temples, and then we would do both virtual and in person. And this went a long way, because if someone's pastor, or someone's rabbi said, oh, I trust these doctors, listen to them, people were much more open to our message than if we had just, because they don't know us, right? If we just showed up and started lecturing to them. So these trusted messengers matter. Religious messengers are important, but it doesn't have to be religious. There's a lot of community leaders. I did a Facebook Live with a councilman in Harlem, because his area was very vaccine hesitant and high risk as well. And that was very well attended because they trusted him. So if he vouched for me, they trusted me indirectly, if that makes sense. Next slide. Among those who attend religious services, most trust clergy as source of information about COVID-19. And this is definitely true. So if somebody is religious, of course, they're going to trust their religious representative the most. So it's nice to see this, but the doctors still were the most trusted, 84%, but second most trusted were clergy or other religious leaders in their house of worship. So this is why we partnered with a lot of these individuals, and I found it very effective. And then as you can see, the news media is the least trusted, and then, politicians are kind of down there as well, but makes sense to me. Next slide. So practical strategies again. Clear communication, education, engage with communities, tailor your message to communities. Legislation and policy may help, but sometimes it backfires. Redirect social media with reliable information, and then address misinformation and disinformation. Next slide. Again, education, the cornerstone of mitigating vaccine hesitancy. You have to combat fears and misinformation with facts. And it's imperative to offer compelling evidence that underscores the necessity of vaccines and really helps people understand the risk of COVID-19. And diverse channels, we kind of had already went through those, but these facilitated and supervised dialogues by community and spiritual leaders really go a long way. Next slide. Clear communication, I won't spend too much time on this, is again going through a lot of the factors and techniques that we mentioned. Next slide. Community engagement, again, trust is key. Build trust with those disenfranchised communities and acknowledge what their fears are, those trusted messengers. And all communication should be evidence-based because you don't want to lose credibility, right? By making wild claims, which may or may not be true. So make sure when you go in as a trusted messenger or with a trusted messenger, you give good quality information. Vaccination programs in communities are also very helpful because when things occur kind of in home turf, people feel more comfortable, more relaxed. They see their own community and friends and family members engaging, then they're more likely to engage as well. Next slide. And again, studies even prove that this is true. 2023 study on vaccine hesitant students found reasons such as fear and apprehension of a new vaccine rather than outright opposition to vaccine. So again, these are people who just need good, clear information. And they also found in other areas, even outside of the US, like in India, for example, that comprehensive approach to amplified loud voices, identifying local concerns and advocates, they achieved successful interventions to bring about long-term change. And other evidence-based kind of guidelines are, community participation, reinforcement techniques, such as incentives or mandates. Sometimes those work in your favor, sometimes they work against. And again, those partnerships with those trusted champions and messengers. Next slide. Legislation and policy. So before the COVID-19 pandemic, vaccination mandates played a crucial role in vaccine uptake, especially for pediatricians and college and pediatric cohorts and college students. Now, again, those mandates have gotten kind of a bad reputation, but they are so important, especially for our young children in that vulnerable age group. Requiring vaccines for school enrollment consistently improve vaccination rates among children because children have to attend school. So majority of parents will comply. However, mandates for adult vaccinations are relatively new, and I don't think that they work as well as they do in the pediatric group, unfortunately. And then these most recent widespread mandates were implemented after the H1N1 pandemic and, of course, during COVID. And they did increase adult vaccine uptake, but in some ways they may have also increased vaccine hesitancy. Next slide. So legislation and policy, again, a lot of things were very helpful, like the vaccines were free of charge during the pandemic, the COVID ones, that really helped because now even if people want to get vaccines and they hear, oh, your insurance won't cover it, or if someone doesn't have insurance and then they go and hear the vaccine's like $200 or $300, they're not going to want to take it. That will be a barrier. So unfortunately, a lot of those policy frameworks that are now gone were helpful in uptake. And this should apply to all vaccines because this is preventative care. It should be covered fully by all insurances. This is my personal opinion. And if you don't have insurance, the government should have funds available to cover it because this is not a personal thing. This affects the whole community. An outbreak anywhere is an outbreak everywhere. Next slide. And this, I know we kind of belabored this, that, you have to have things to counteract misinformation that you find online. Next slide. And again, this is just some more tips. One approach that was demonstrated during the pandemic at the Cleveland Clinic where pregnant doctors, nurses, and pharmacists shared their reasons for receiving the COVID-19, and that really helped influence vaccine uptake in that group specifically. And I have a personal experience with that as well. So when people see that, oh, my healthcare worker is doing it and they're in the same boat as me, they're more likely to increase that uptake. Next slide. And of course, addressing misinformation and disinformation. And there's a lot, especially in the reproductive health space and in the pregnancy space, there's a lot of misinformation from infertility to the microchip, to you name it. There's a lot of crazy things that I had heard. But the problem is a lot of people believed it because they thought they were getting this information from reliable sources. So rather than disparage people for believing these things, you have to help show them why that information is not correct. Next slide. Okay, so research and innovation. Investing in research, especially to include vulnerable groups, that will make people more likely to take something. Up until now, most research majority of participants are Caucasian. So there's a relatability factor, but including vulnerable groups like people of color, children, pregnant individuals is crucial to counter this vaccine hesitancy. And so the scientific community must also acknowledge its role in vaccine hesitancy, especially among these underserved populations. And we need to do better at addressing both epidemiologic and socioeconomic factors. Next slide. I'm going to skip over this just so we can get to kind of the current guidelines. Next slide. Yeah, I'll skip over this. And then again, it's really important to incorporate vaccination into routine prenatal care. This is a very high risk group. This is especially important for any of you that work in the OB world. You play a huge role because every pregnant woman sees their OB and OB office staff the most, almost monthly or weekly. So this is extremely important. Next slide. All right, so this is, I wanted to touch on this before we go to the questions. So the current guidelines for immunizations for people with respiratory disease, this is important. So for COVID-19, the CDC currently recommends that everyone who is at least 6 months of age or older should receive an updated COVID vaccine. And the current vaccines available, there's 3. There's Pfizer and Moderna, both have updated vaccines. They're the mRNA vaccines that we had been hearing about through most of the pandemic. But Novavax is now also available. And this is actually a adjuvanted protein vaccine, which is similar to shots that people have received in the past. So this is great. This one is great for vaccine hesitant people because a lot of the misinformation is around mRNA vaccines and what they do and them being experimental. But Novavax is the old tried and true technology that people know and trust. So a lot of my patients I've been able to get vaccinated by telling them about the Novavax vaccine. And unfortunately, again, there's not good information out. Like many people don't even know that it exists. So that's an option that you can always give your vaccine hesitant people. It's also helpful to those people who've had adverse reactions to the mRNA vaccines, such as allergic reactions, or if they've been the unlucky few to get myocarditis or very severe side effects. So it's nice that we have a non-mRNA option, and that one is also updated so that one also is applies to the current strain. So that's for age 12 and up, the Novavax. Next slide. And then for the flu vaccine, CDC recommends this for age 6 months and up, as always. And again, this should be updated every year. And the ideal time to get the vaccine is end of September, October, and that should carry you through the entire flu season. If you get it a little early, that's all right, or a little late, it's all right. It generally lasts at least 6 months or more in most individuals. Next slide. And now there's some new players on the scene as of last year. So the RSV vaccine is one I get asked about a lot because I have a lot of immune compromised and asthmatic patients. So the CDC recommends a single dose of any FDA licensed RSV vaccine for all adults age 75 and older, and adults 60 to 74 who are at increased risk of RSV. So what does that mean? Those who are increased risk for RSV could be people with asthma, COPD, heart disease, cancer, anything that would put you at higher risk for getting a respiratory vaccine would qualify. So GSK has one, Moderna has one, and Pfizer has one. Eligible older adults may receive any of the licensed RSV vaccines, and adults can get the vaccine at any time, but the best time is late summer and early fall before that RSV season starts. And the good news is this one you don't have to get every year. So I believe the immunity lasts at least minimum 2 to 3 years, maybe longer. So that's one break that you get. Next slide. The RSV vaccine is not annual, as I mentioned. If you've been vaccinated, again, you don't have to get one again every year. Pregnant women also should get the RSV vaccine between 32 and 36 weeks of pregnancy, because the cool thing is then that immunity also transfers to the newborn, and the newborn is protected their first 6 months of life. And I received it myself when I was 32 weeks pregnant. Infants should get a monoclonal antibody once between birth and 8 months for RSV before their first RSV season, or up to age 2 if they're high risk. So even though I got vaccinated against RSV, my son got his RSV vaccine as well when he was 6 months old, because my immunity wore off by that point, so I wanted to make sure he was protected for the whole RSV season. Next slide. So vaccines work, just to kind of summarize, they work. They're one of the greatest public health innovations, even though they're getting a bad rap today. There's overwhelming data on their safety and efficacy, and one of the few preventative health interventions that are effective within weeks, right? So we do so many things for prevention, exercise, taking medicines, eating right, and none of it works in a few weeks, except for vaccines. And I get asked this a lot as immunologist, but how to boost my immune system. This is the best way to do it and the fastest way to do it. And everyone, not just healthcare workers, can help combat hesitancy. So you don't have to work in healthcare to help convince somebody. Be kind, empathetic, compassionate, meet people where they are. That you're much more likely to attract flies with honey, as they say, than vinegar. And it's all in our best interest to combat hesitancy, because outbreak anywhere is an outbreak everywhere, right? We're protecting each other. All right, sorry that was a bit long. I had a lot to say, but I'll open it up for questions.
Thank you, Dr. Parikh, really appreciate it. And I'm sorry, I'm sitting here in the dark now. The sun went down, so I apologize. So we did have some questions that come in, but I just wanted to comment. We had special webinars for the Black community and the Hispanic Latino community during COVID. And we actually did evaluation of vaccine hesitancy before and after, and found that when those trusted messengers from the communities in which these folks lived were actually talking to their community and explaining the safety of vaccines and that it was okay to take the COVID vaccine, that they were more apt, and we showed it in the evaluation data, to do that. And with the Hispanic Latino community, we actually started doing the webinars in the Spanish language. So the doctors who were talking to those attendees were hearing it in their native language. Do you want to comment on that?
Yeah, I think that's excellent. And I agree, because I participated in some of those webinars and I thought they were really impactful, especially as you mentioned, if people see a doctor that looks like them and speaks the same language as them, it goes a really long way. And yeah, I think they were just wonderful. And I'm glad that you all have continued those webinars, even for non-vaccine related topics, because this hesitancy, I think, carries over into all aspects of healthcare. So a lot of fears people have about vaccines also, may apply to asthma medications too. So yeah, it was a great series of webinars.
Yeah, thank you. So I have some questions here. You did earlier in your presentation, you said something about nurses and LPNs. I'm sorry, nurses were less likely to be pro-vaccine. Can you comment on that, and whether it was mostly RNs or LPNs or both?
Oh, that's a good question. So I don't know if it's more so one type of nurse, but I can get the data, the study to you. We'll send it out afterwards. But yeah, they did show that the uptake among nurses, it was somewhere between 50 to 60%, whereas physicians or other physicians I know was closer to in the 90%. But I didn't see a breakdown of NPs versus LPN versus RN. That would be very interesting. So because that might be a difference as well. And I found it interesting that again, people working on the same healthcare team might have a very different view of the same intervention, right? So it's really important to connect with people about why they have that view. And again, most of the nurses I work with take the vaccine, right? So my view of it is very different than someone else who may work with somebody who's very much against it. So I just found it very interesting that there was such a disparity even amongst healthcare workers.
Understood. Yeah, great. Thank you. If the CDC is not considered a trustworthy source by people, are there other sources that you can recommend that people go to get their information?
Right. So I completely hear you on that. CDC and NIH, but they had a lot of erosion in trust during the pandemic. I always recommend, I like a lot of hospital websites are very good. So the Johns Hopkins Hospital had great information all throughout the pandemic that I found very helpful. And then also organizations like the Allergy Asthma Network, right? People trust organizations where their peers are there, so where other patients and families may be there. So Allergy Asthma Network has great information. American College of Allergy, Asthma, Immunology, and the American Academy have great information on vaccines to combat vaccine hesitancy. And there's a whole myriad of groups like that. So American Heart Association, which is largely a patient group, also has great information because vaccines affect almost every chronic medical condition. So you can definitely find patient advocacy groups that have great information that I think are much more trusted than the CDC or NIH right now.
Okay, I'm going to give one more question because it's 5 o'clock. Is the
Yes, sorry.
That's okay. It was a great presentation. Oh my gosh, so packed with information. Is the COVID booster still to be spaced a year apart? Are they still called boosters? I noticed you just were referring to them as vaccines.
Right. Yeah. I refer to them as vaccines. They are technically still called boosters, but the reason why I still call them vaccines is because some people may not be up to date with their boosters or may not have even received the initial vaccination. And unless you're a baby or a child, you don't have to go through that initial vaccination. Even if you've never had the vaccine, you can just start with the updated vaccine, like if you're an adult, for example. So that's why I use the terms interchangeably. But yes, they are technically boosters, and they are annual for most people. There are some high-risk groups that might need it more than every year. So they're like, for example, people who are severely immunocompromised can get it even every 6 months. And that same goes for the flu shot with, like, cancer patients undergoing chemotherapy or what have you, or certain groups of elderly that have chronic issues or severe lung disease. So if you think you're in that group or know someone in that group, it's best to discuss with their doctor if there's someone who should be getting it more often, because there are certain high-risk groups where it is recommended more often.
Well, great. Well, with that, I'm going to say thank you so much for this wonderful presentation. It's been really packed with good information, and
Yeah, it's overpacked.
really appreciate your time on that. Can't imagine how long it took you to pull all that together.
Right.
We're in the process of planning our 2025 webinars, so please look for emails from Allergy and Asthma Network for upcoming webinars next year. And remember, in a few days, you'll get an email from Zoom with some list of additional resources related to this webinar topic and other things that might be of help to you. Thank you again for all of us at Allergy and Asthma Network. Join us every day where we work better. We work to help people breathe better together. Have a good night, everyone.
Thank you.